You are still functioning. Your patients are being cared for. Your colleagues haven't raised a concern. You show up for your shifts. You do the work, and you feel nothing. Not nothing is in bad. Nothing is in flat. The clinical case that would have engaged you completely 3 years ago now registers as a task to complete. The patient who needs your attention gets your attention, but not your interest. That is not laziness. That is burnout in its operational phase. Hi, I'm Chet Shermer, and I've been working in emergency departments throughout Mississippi for 25 years. I've witnessed colleagues burn out and also known fellow physicians who continue to thrive despite the significant demands of our profession without missing a beat. Let's learn more to recognize this common malady associated with our profession. Burnout in emergency physicians does not announce itself. It does not arrive as a sudden crisis. It accumulates gradually, below the threshold of awareness until the cumulative load becomes impossible to ignore. The Maslach model describes three components: emotional exhaustion, depersonalization, and reduced sense of personal efficacy. What makes emergency medicine burnout particularly dangerous is that each component can develop independently and be rationalized away as something else. Exhaustion is attributed to a difficult stretch of shifts. Depersonalization, the emotional distancing from patients, is called professionalism or clinical detachment. Reduced efficacy is dismissed as imposter syndrome. The result is a physician who is significantly impaired in their engagement with the work, who has no framework for what is happening to them, and who continues practicing medicine while the deficit compounds. Emotional exhaustion is the first component to emerge in most EM burnout presentations. It is the depletion of the emotional energy required for sustained empathic engagement. Emergency medicine asks for enormous emotional output. Every shift you manage patients in acute distress, physical and psychological. You deliver bad news. You witness trauma. You make decisions under uncertainty with consequences that are immediate and sometimes irreversible. That emotional output requires recovery. When recovery is insufficient because of shift density, systemic stress, inadequate time off, or unresolved accumulation of traumatic exposure, the reserve depletes. The early sign is not breakdown. It's reduction, less engagement, less curiosity. The patient interaction that used to take 4 minutes of genuine connection now takes 90 seconds. Depersonalization follows emotional exhaustion as a protective mechanism. When emotional reserves are depleted, the psyche builds distance between the practitioner and the source of the emotional demand. In practice, this looks like objectification, thinking of patients in terms of diagnoses and dispositions rather than as people. Cynicism about patient motivations, reduced tolerance for complexity or ambiguity, a shift from curiosity about the patient's story to urgency about the patient's throughput. This is not a character defect. It is an adaptive response to a system that demands emotional output without providing adequate recovery. But it degrades care quality, increases the risk of cognitive shortcuts, and is invisible to the physician experiencing it. The third component, reduced sense of personal efficacy, is where the physician's professional identity begins to fracture. It is the sense that what you're doing no longer matters, or that you're no longer effective at doing it. Emergency medicine attracts practitioners who define themselves by their ability to function under pressure. When that sense of efficacy erodes, the psychological impact is severe. It does not respond to reassurance or logic. It is not fixed by a compliment from a patient or a good case outcome. It requires systemic change in workload, in recovery, in the meaning the physician finds in the work that most emergency departments are not designed to provide. The biggest barrier to burnout recognition in emergency physicians is the same trait that makes them effective clinicians: high threshold for self-diagnosis. Physicians who self-screen for distress apply the same diagnostic skepticism to themselves that they apply to patients. I'm not really burned out. I'm just tired. I've had harder stretches than this. Add to that the medical culture that pathologizes help seeking and the licensing implications that can follow a mental health diagnosis, and you have a population that is systematically underscreened and undertreated. The physician who needs help the most is also the physician most likely to rationalize why they don't need it. Three things. First, conduct an honest assessment of your engagement with the work. Not whether you're functioning, you're clearly functioning, whether you're present, whether you're curious, whether the work still feels like medicine or just task completion. Second, Do not wait for a crisis to seek support. The physician who addresses early burnout signs with appropriate intervention has a fundamentally different trajectory than the one who waits for collapse. Third, if you are a leader or supervisor, normalize the conversation. Ask your colleagues how they're doing in a way that invites honesty rather than performing wellness. This is Global MedOps Command, Clinical Brief Series. Burnout is a system failure that presents in individual physicians. Address the individual, demand better of the system. Next brief, the quiet career risks no one warns EM doctors about. Stay prepared. Stay educated. Out.